Hello and welcome to another Piper Pod. Today we're going to continue with the pathophysiological lessons, and we're going to look at the endocrine system. Now, the endocrine system historically has been one that most people try to avoid for a couple of reasons. One is obviously it's a very complex and entwined homeostatic type system, as in every hormone seems to have a flow-on effect to another hormone, and it's all involved in balancing the body and making sure everything works right. And also, we don't see a lot of endocrine disorders, except for obviously diabetes type 2, but even that is quite rare, especially in the Defence Force. So endocrine pathophysiology is not often spoken about and usually avoided at all costs. So what we're going to do is hopefully just shed some light on a few disorders and just knuckle down on the important parts of endocrine disorders and what we can actually get out of it and make a difference for our patients. So just as a means of introduction to the endocrine system, I'll just remind you, just a short overview. We're not going to go a lot into anatomy physiology. If you forget a lot to do with the endocrine system, then you really need to go back and have a look at the anatomy physiology lesson, because you will need that knowledge in order to follow along what's happening. Now, endocrine system is a small size system that has a very large function in the body. It comprises of organs and glands throughout the body, and they secrete hormones directly into the bloodstream to reach target areas or target organs. Each one of those glands and organs are independent of one another. They don't actually have any connecting neural connection or anything like that. They are absolutely vital in maintaining homeostasis. Now, they act on receptors that are found throughout the body. Now, two different types of hormones, technically three, but two main types of hormones are available in the body, and that is fat-soluble, and then you've got your protein-based as well. Now, they will react on receptors based that is found on the plasma membrane or actually inside the target cell itself. So different hormones have to move into the cell in order to have a function, whereas other hormones can react on the exterior wall of the cell membrane. That comes into play when we talk about different disorders. When we look at a particular gland itself, it's a ductless gland, and it's surrounded by lymphatic and vascular tissue, so it has full access into the body. Some of the organs that are associated with the endocrine system have other functions as well. Obviously, your kidney, your heart, and even your pancreas has both endocrine and exocrine based cellular tissue. Now, if we cast our mind back to anatomy physiology, we'll remember that most hormones work on what's known as a negative feedback system. That's where a stimulus activates a certain hormone that activates a certain hormone, and then one of those hormones, whilst it has an effect on the target cell, often has a secondary effect to turn off the releasing endocrine glands. So the endocrine glands that play a massive role is any time that we're working with the hypothalamus pituitary axis is when you'll find this negative feedback turn off type thing. Other types of negative feedback work on your neural stimulus or your humoral stimulus as well, and that's also true for when we're dealing with the release of hormones. Now, hormones can be released a number of different ways. The first one in alpha, you'll see an example of humoral stimulation to release the actual hormone itself, and this one's got to do with the depletion of ionized calcium that's found in the bloodstream. When that's denoted, the release of the parathyroid hormone is conducted by the parathyroid gland. There's other hormones that are released through direct neural control, as we'll see in B. Now, this neural stimulus is usually associated with the sympathetic nervous system fibers directing straight into the medulla of the adrenal glands, and it's used to release adrenaline and noradrenaline, or our catecholamines. And the last one, Charlie, which is probably the main way in which hormones are released, and that's through hormone control. So your hypothalamus has a whole bunch of trophic-based hormones that stimulates the release of other hormones in the pituitary gland. And the pituitary gland release another lot of trophic hormones that release hormones from other endocrine organs. And that is the most common way in which hormones are released. The reason that's important is because we need to look at the basis of endocrine disorders. Now, the fundamental basics of endocrine disorders goes all the way back to either having a hormonal hyposecretion or a hormonal hypersecretion. So when we're dealing with hyposecretions, the most common causes that we'll find out there is it's either a congenital, which causes an inborn error to do with metabolism, or a lack of vascularity associated with the organs. We can also have different types of ischemia, and then we can also have autoimmune disease. It's where antibodies will target hormone receptors, and it usually ends up causing atrophy of those glands. Whereas when we look at hypersecretion of a hormone, the most common causes is functioning tumours. So that's got to do with the production of large quantity of hormones from tumour-based tissue found in the endocrine system that is still functional. So it still has the ability to actually release hormone. So it's sort of like dysfunctional hyperplasia of that endocrine gland. Now we can also get, just focusing on tumours, we can get other tumours. They're not located in the actual endocrine organ itself, but it's called an ectopic tumour that can secrete hormones. Now, classic case for that is lung tumours, that they can release hormones and act as though they were endocrine glands. Other things that causes hypersecretion is our hyperplasia, and then again our autoimmune disease. There's a lot of autoimmune disease. In this case, the antibodies will actually target the receptor sites of a particular gland. Now we'll look more into this when we start looking at the pituitary gland itself. Now, other pathological basis of an endocrine is we can either have either one of those two. You can have a hyper or hyposecretion of the actual hormone itself, or they can be functioning normal and you'll have an extraglandular disturbance. And the most common form of extraglandular disturbance is where you'll actually have antibodies that are designed to attack the hormone itself. So they will bind to the hormone molecule, making it impossible for that hormone to bind to the actual receptor site. Okay, some classic examples of that is your Hashimoto's disease and your Addison's disease as well. And the last type is when we have altered tissue response. This is where the hormone molecule is intact, but our actual receptor sites at our cell membrane or in our cell are no longer functioning. So they have less receptor sites to pick up the hormone. Therefore, it's almost like a hypersecretion type disorder. And a classic one of that is your diabetes mellitus type 2. Okay, let's focus on the pituitary gland. Now, this gland is absolutely tiny. Okay, it weighs about 500 milligrams. That's about it in most people. But it has a huge role. It is heavily involved in the negative feedback system and gets its responses directly from the hypothalamus in the brain. Now, it has been called in the past the conductor of the endocrine orchestra, and it's located in an area at the base of the skull called the sella tunica, just for your knowledge. Now, it's divided into two different parts, the anterior pituitary gland and the posterior pituitary gland. Now, each one of those are under direct control of the hypothalamus in the system known as the hypothalamic pituitary axis. But the cells will actually populate each area populates different types of hormones. So the anterior pituitary gland is associated with the excretion of your trophic hormones, and that is hormones that act on releasing other hormones, all except for prolactin, which as an interest base is one of the only ones that works on a positive feedback system as well. Now, the posterior pituitary is your neurological based one, and that actually releases hormones itself. It doesn't produce them, it just releases them. So what we'll do is we'll just talk about conditions of hypofunction within the pituitary and then conditions of hyperfunctioning pituitary. So when we look at pituitary hyperfunction, it is often caused by a number of different types of conditions. The first one is usually your congenital one, which is associated with the underdevelopment of the gland itself. So in the event the gland is actually smaller than it should be, you'll end up with an overall reduction in all the hormones that it produces. Now, this is a condition that can cause things like pituitary dwarfism that we'll have a look at in a little bit, and it's associated with a condition called congenital hypopituitarism, so an overall reduction in the amount of all the pituitary hormones that are excreted itself. The next type is ischemia. So if the actual pituitary gland gets damaged, tissue dies as a result of ischemia, then obviously you're going to have a reduction in the amount of hormones that can be produced. Now, a classic example of when this occurs is actually during pregnancy. So during pregnancy, your pituitary gland enlarges and it becomes increasingly vascular. So a postpartum hemorrhage of the actual pituitary gland can lead to ischemic necrosis of the pituitary itself, and that's called a Sheehan's syndrome, and that's one of the leading causes of acute pituitary hyperfunction. It can also have ongoing effects, and it is usually picked up in failure to lactate. So prolactin deficiency, failure to lactate, and that's usually where the first signs are found. Other ways to get your pituitary hyperfunction is associated with compression of the pituitary within the silica tunica itself. Now that can be caused by a metastatic carcinoma or adenomas, and you can also have areas where you get damage to the hypothalamus or the pituitary stalk itself. Now looking at the other end of the scales where we have pituitary hyperfunction, now their main causes, most commonly anyway, are associated with the pituitary tumours, either directly affecting the area or indirectly putting pressure in the area itself. So each of these particular ones can be divided from the hormones producing cells. So you can have your prolactomas, your somatotropic adenomas, corticotropic adenomas, gonotropic adenomas, or thyrotropic adenomas, based on the cells that release certain hormones and what functions you have. But all of these particular ones can be either functional or non-functioning tumours. So just because you have a tumour in the area doesn't mean that all the cellular, all the dysplastic formation has to be functioning. But when it is functioning, as I mentioned, you have unregulated dysfunctional hyperplasia, for lack of a better term, and that causes the unregulated release of hormones and therefore hyperfunction. You also commonly get a local effect, which is visual problems, because where the pituitary gland sits, if that increases in size and mass, it's actually going to put pressure on the optic chasm, which is where the optic nerves will actually cross over to go to the different parts of the brain. Focusing on a particular hormone that is released, just for interest based, we have our growth hormone. Now normally our growth hormone is released during increased protein intake, exercise, stress, and our sleep cycles. And growth hormone is reduced in the presence of somatostatin and the presence of high glucose as well. Okay, so they're things that normally release the hormone. When we have growth hormone excessive disorders, we have two main ones. So in the event that growth hormones are released en masse, the first one, which is giantinism, which is denoted by the picture on the left of the really, really tall man. Now this is associated with childhood onset, and that comes with very, very tall-like structure because it happens in childhood, which means it's designed in rapid bone growth before the epithelial plates have fused. So because the epithelial plates of the bones haven't fused, you have a markedly increased potential for growth. Unlike acromegalia, which usually hits in your adult years, and that is characterized by enlargement of your hands, head, and feet, and it's often secondary disorder to diabetes, and that's where you'll come with a lot of different type, sizes, symptoms. Obviously you've got the growth of the hands and feet, but then you also have an increased probability of osteoarthritis, complications of diabetes, organ enlargement, cardio enlargement, hypertension, and you can also get mental disturbances as well. Okay, so that's all got to do with the hypersecretion of your growth hormone. Now, on the other side is growth hormone. It's a congenital disorder that happens at childhood, which is your pituitary dwarfism. So it's often associated with short stature, and causes are congenital, and it only happens when you have pituitary failure in childhood itself. Okay, let's leave the pituitary gland alone and we'll move down into our thyroid gland. So thyroid is located at the anterior triangle of the neck, and it weighs about 20-30 grams, and there's two lobes on the either side of your actual neck itself. Now the main hormones that it secretes is your T3 and T4, and they're under the negative feedback control of the thyroid-stimulating hormone. So your hypothalamus will actually secrete your thyrotropin, which stimulates thyroid-stimulating hormone, which stimulates the release of T3 and T4. It is very, very important in regulating metabolism. It acts on every cell in the body, both T3 and actually T4 is broken down into T3 to be used a lot of the time, but it regulates metabolism. Now another thing that the thyroid does is the parafollicular cells, or C cells that you can call them, they're responsible for releasing calcitonin, and they act to reduce high calcium. So in the event that we end up with hyperthyroidism, that is obviously just an elevated level of the thyroid hormone. It can be just hyperthyroidism, and we can also have a thyroid toxicosis or a thyroid crisis as well that we'll look at, which can be more of an acute syndrome. Now the main causes of your hyperthyroidism is your thyroid adenomas, your Graves' disease, toxic nodule goiters, and then your endogenous thyroid medication. So the way they work, if we look at the picture on the left, the nodule goiter and the adenomas, they will release an increased amount of thyroid stimulating hormone. They do inhibit thyroid stimulating hormone, but in the event that the actual adenoma has produced functional tumour growth, then it's going to release a hell of a lot of your thyroxine. Now same with the nodular goiter, if that's associated with rapid functional endocrine tissue, then again you're going to have an increase in the amount that can be released even on the small stimulus of the thyroid stimulating hormone. Okay, now your thyroid pill, the only way to get hyperthyroidism from thyroid medication is to take too much, or have an inability to excrete or metabolize it. It's an error that happens. So the most common way that happens all the time is in the presence of Graves' disease, and that is where you'll have antibodies that will actually mimic your thyroid stimulating hormone. And what they do is the antibody comes along and it binds to the receptor site that the thyroid stimulating hormone does and activates the release of your actual T3 and your T4. And your classic signs and symptoms of just pure thyroidism is basic heat intolerance. You have tachycardia, long-term associated with weight loss and muscle wastage, increased appetite because your metabolism is going haywire, and you can end up having localized tremors and diarrhea are the main symptoms that you'll find. When we move on to thyroid storm, then you are dealing with a potentially dangerous, can be fatal condition, which is usually associated with an acute increase of your thyroid levels. The most common causes of your thyroid storm is thyroid gland surgery or an infection. Now the difference between hyperthyroidism and thyroid storm usually works with a scale like this. And if you end up having more than 45 points in the scale, then you're in a thyroid storm. And your big clinical features is profound hypothermia, tachycardia, and then you can also have central nervous system disturbances as well, all the way up to seizures, psychosis, things like that as well. Okay, so often these scales are put in place for thyroid storm because it's a means of picking up potential thyroid storms early and then treating them from there, as opposed to waiting until they're in the thyroid storm and then really trying to resuscitate someone from a thyroid storm is not the easiest thing to do. Right, when we're dealing with hypothyroidism, we're obviously dealing with the other end of the spectrum itself. So we're dealing with a reduction in the release of thyroid hormones. Now, the most common causes of that is your Hashimoto's disease, and that is by far the most common cause of it, and it's an autoimmune disease. And in this case, the antibodies will actually target this synthetic pathway of the thyroid hormones. So they will come along and they'll actually attack the pathways in which the thyroid hormones travel, and then it leads to the hormone insufficiency. And that eventually will lead to your gland fibrosis, okay? Because it's like a precursor to inflammation, because it blocks your secondary enzyme activity. And that inflammation causes fibrosis, which means that tissue is being replaced with non-functional tissue. So not only does it actually affect it initially, but then it causes long-term effects, which includes your fibrosis. And this often results in the actual thyroid shrinking dramatically in size as well. But other things that can happen is you can have an iron deficiency. Okay, so what defines T3 and T4, just for interest's sake, is T3 has 3 iron molecules attached to it, and T4 has 4, meaning that iron is absolutely vital for the production of your thyroid hormones. Okay, so obviously if you have a deficiency, you're physically not going to be able to produce the hormones, causing hypothyroidism. And the last one is certain medications and removal of the thyroid gland is obviously going to cause hyperthyroidism. Now, your signs and symptoms are the opposite. You have cold intolerance, you're freezing all the time, always cold. Your body, your metabolism, everything slows down, so your pulse is slower. You gain weight. You're not really hungry because you're not burning anything off. Your gastrointestinal system slows down, your mental stability slows down, so you end up always fatigued, slow speech, can't really think properly, and it's usually associated with your different types of hair loss. Okay, so hyperthyroidism is hair loss. Hyperthyroidism gives you thinning of your hair as well. So your skin loses its tone, your nails and everything fall apart, and it's not obviously a very nice disorder, and it's treated with thyroid medication. Now, something that can occur as a result of hypo or hyperthyroidism is the presence of a goiter, and that is just an enlargement of the thyroid, often associated without hypersecretions of that hormone. Okay, so it's not a tumour growth necessarily, and if it is a tumour growth, it's associated with non-functional cells. Okay, but the main causes is your hyperplasia, okay, and your iron deficiency. But it can happen in hyperthyroidism as well, as a result of this dysfunctional tissue and the need to produce more thyroid gland from dysfunctional parts. So you get a larger thyroid, but still only functioning about the same. Hypothyroidism, it causes because one, you've either got a tumour blocking it, or you're trying to produce more cellular or endocrine-based tissue that can release more hormones itself. Okay, the parathyroid gland are the small tiny glands found within the thyroid gland themselves. Now, 90% of people have 4 of these tiny glands, but people can have up to 8. They are tiny in size. Okay, these are vital in the calcium phosphate homeostasis. So they're responsible for secreting the parathyroid hormone, and it works on a negative feedback system and your humoral control. So when you have hyperparathyroidism, that is releasing too much parathyroid hormone. And their main causes are associated with parathyroid hyperplasia, chronic kidney disease, which is a rare one. It's got to do with vitamin B synthesis dysfunction, certain medication abuse or medication that causes parathyroidism, and then you've also got your parathyroid adenomas themselves. Now, what happens in the presence of hyperparathyroidism is release of the parathyroid hormone causes the bones to release a hell of a lot more calcium and phosphorus that is released into the blood. On top of that, it tells the kidney to increase the reabsorption of calcium and increase the excretion of phosphorus. It's sort of like a balancing act. It also releases a huge amount of vitamin D that tells us the intestine to have a lot more uptake of calcium from the mucosa itself. So the end result is you end up with hypercalcemia and hypophosphatemia itself. Okay, the other end, hypoparathyroidism, that is the reduction in the secretion of parathyroid hormone, which is a very, very rare condition. Okay, its main causes can be idiopathic, ionogenic accidents, surgically removing the parathyroid glands along with the thyroid tissue, and specialised, not real quantified, autoimmune diseases. So more of those focused ones. Now your clinical features are going to be exactly the same as hypocalcemia. So you're going to get your tetany, you're going to get your cross-check sign, your Tulsa sign, tingling of the hands and feet, and you can get arrhythmias associated with a prolonged QT because of the lack of calcium. You can get that inability to stabilise the cardiac tissue itself. Okay, that is thyroid glands done, so we'll move all the way down to the top of the kidneys and we'll talk about the adrenal glands themselves. So when we look at the adrenal glands, they're broken up into two different functional endocrine tissue. So we have the adrenal medulla, which is the inside associated with the release of catecholamines, and then you have your adrenal cortex, which is associated with steroid hormones release. It's vital for metabolism, immune system, water electrolyte balances, and that is broken up into three different zones. Okay, so your first zone is associated with your aldosterone-based ones, so your water and your enzyme activity. Then you've got your cortisol-based ones associated with all your steroid-based hormones, and then you got your androgens, which is your sex hormones themselves. So looking at problems with the adrenal cortex itself can be traced back to those zones itself. So when we're dealing with hyper secretion of the adrenal cortex, we'll start with the zona glomerulosa, which is associated with your hyperaldosteremia, so an increase in the amount of aldosterone that is produced, and that syndrome is called Conn syndrome. Now, because you're having a huge amount of aldosterone release, you're obviously going to have problems associated with water balances. Now, its main causes is your adrenal adenomas or your adrenal hyperplasia itself. The clinical findings of this is the patient's going to have hypertension, muscle weakness, and cardiac arrhythmias they can have, but your chemical findings can be obviously huge levels of aldosterone, very low levels of renin, and a profoundly low hypocalcemia. So obviously potassium very, very low. The middle zone, as I mentioned, is responsible for releasing steroid-based hormones. So the classic hypersecretion disorder is your Cushing syndrome. So Cushing will result in a huge amount of cortisol release. Now the causes you can see in the picture to the right, but there can be ionogenic diseases associated with steroid administration. So obviously you're just putting a lot of steroids in there. So you're taking over the cortico and you're getting hypersecretions from the steroids itself. But then you have again adenohyperplasia and adenomas, and then you can have an excessive amount of ACTH as well, which is your angiochronotropic hormone release. So if that gets excessively released from the pituitary gland, or ectopically be released from those cancers I spoke about in the lung tissue, then you're going to have an increase of cortisol that is going to be set through the body. Now the clinical symptoms of this is you'll have centralized obesity, so fat storing around the stomach, hairy-tourism, so growing hair in areas you don't want, hypertension, diabetes, osteoporosis, clotting problems, and it's usually really hard for simple wounds to heal as well. Okay, another type of hypersecretion within the adrenal gland, we're just going to jump to the actual adrenal medulla itself. Now, pheochromocytoma is associated with the excessive release of your catecholamines. Okay, so it affects the medulla, and it's the clinical release of a huge amount of your catecholamines. Now, obviously, your clinical features, you've got a huge list down the left-hand side. The main ones, as you'd imagine, hypertension, sweating, nervousness, headaches, increased heart rate, that sort of thing. Okay, so everything to do with an adrenal surge, but long-term as well. This one here is usually diagnosed with checking out the urine and looking at your catecholamine breakdown products, so an area of enzyme activities and things like that is what you're actually going to find in the urine to get the diagnosis. But it's quite rare, luckily, and it's obviously main causes is your adenomas or hyperplasia of the actual adrenal medullary tissues. Okay, looking at our hypo secretions can pretty much be defined as adrenal insufficiency. So it's a class of disorders that pretty much takes care of all the causative agents that will cause a reduction in the amount of hormones that are released in the area. Now this can either be short-term as a result, so problems associated with short-term response, so no more sympathetic response or adrenal surge, but then you can also have longer-term response when you increase cortisol levels, which increases your blood glucose levels, your protein, your fat metabolism, and you can also have aldosterone that can fail, helping to maintain the blood volume. So it can be fatal, particularly when associated with acute insufficiency. So the causes of adrenal insufficiency, we'll look at the chronic causes themselves. So if we look at number one, the one on the far left-hand side, this is associated with your Addison's disease itself. So this is where you'll actually have antibodies or autoimmune antibodies that will destroy the cortex of the actual adrenal gland, and that will obviously cause a decrease in hormone secretion, which means that you'll get an insufficiency developed. So your plasma stimulating hormone or trophic hormone is normal, but you just don't have enough tissue that's being developed, and the whole cortex gets affected. Now, the second one is more associated with both acute and chronic. So in the acute stage, it's associated with severe bacterial infections, meningoid type infections that you'll get. They'll actually come in and they'll destroy the tissue as well. It's chronically caused by TB, and it also can be clinically caused by carcinomas of the actual area or amyloidosis as well. And this is where you'll actually get full destruction of the adrenal gland. So the cortex and the medulla will be broken down, and it doesn't matter how much stimulating hormone you have, you will not be able to release any of the adrenal hormones itself. And the last one is associated with steroid withdrawal. Okay, so secondary adrenal insufficiency is mostly associated with gross steroid withdrawal. So the way that works is your ACTH initially will be released, but then if you're taking steroids, all of a sudden your body never registers as a low level of this cortisol or these steroid-based hormones. So your ACTH, basically, it just doesn't function. So when you have long-term high doses of steroids, then your ACTH loses its ability, its fine-tunedness to be released to stimulate the cells, because the cells have never actually had to release anything. They've never actually had to do anything itself in regards to cortisol release. So it stops that function. And then if you try to bring back that function quickly by not taking any steroids, then it can take time, and you'll end up with an adrenal insufficiency as a result of it. So the two middle zones is actually what atrophies and actually becomes ineffective, but the outside associated with aldosterone release and the inside associated with catecholamines are perfectly fine, but your overall trophic hormone is reduced. So the big findings from a lab point of view is you can end up with hyponatremia as a result of aldosterone insufficiency, depending what it is, which will turn into hypovolemia as well. And you can also get hyperkalemia when you're dealing with adrenal insufficiency. Clinical signs for your acute stage, people will get postural hypertension and profound dehydration, nausea and vomiting. Chronically, they become anorexic, their pigmentation will change in the hands and mouth, they'll have chronic abdominal pain, usually weight loss, and massive fatigue as well. Okay, let's finish it off and we'll look at our pancreas. Okay, so the pancreas is one of those ones that is associated with an endocrine and an exocrine gland. The ones that we're particularly focused on today, obviously, is the endocrine cells, which is the islets of Langerhans, and they take up about 1 to 2% of the total cells of the pancreas. So it's mostly an exocrine tissue. The islets of Langerhans are responsible for releasing 4 hormones. Your main one, 70% of tissue is taken up by your beta cell that releases insulin. Your alpha cells, 20% glucagon, and then you've got your delta cells that release somatostatin, and then you've got your PP cells that release something known as a pancreatic polypeptide, and we don't actually know what that does. Now, the main disorder associated with the pancreas is obviously your hyposecretion of your endocrine substances, which causes diabetes mellitus, which is what we'll look at mostly. Disorders associated with hypersecretion are way less common, and they're usually associated with benign cancers. So you can have an insulinoma or a glucagonoma that obviously will increase the amount of hormone depending on insulin glucagon that is released. Now, diabetes mellitus has been classified as a type 1 and type 2, but the end of the story is it's associated with hyperglycemia, obviously. So it's defined as a metabolic disorder, which is disturbances in metabolism of carbohydrates, lipids, and proteins within the body. It's only defined by type 1 is usually congenital, as in it has a link, and it's often associated with people getting it when they're less than 30, and it's associated with a decreased level of insulin that is actually flowing around the body. So an insufficiency of insulin that is flowed around in the body. Now, diabetics type 2 can most usually starts with enough insulin in the body, and then either ends up with not enough insulin to meet an increased demand, or not enough receptor sites at the muscles able to pick it up, so you get insulin resistance. And then over time you can get a mix of insulin resistance, hypoglycemia, and then a secondary insufficiency of insulin being produced. So it gets quite tricky, which is why we've gone away from calling it insulin dependent and non-insulin dependent, because whilst type 1 will definitely get insulin all the time, type 2 usually controlled with diet, oral hypoglycemics, but can often need insulin as well. The reason for the big difference is type 1 is usually associated with antibody attack on the islet cells themselves, which means a loss in your actual beta cells, whereas type 2, your beta cells are usually quite normal. Now, the end result is we're going to get hyperglycemia, which causes a whole amount of problems. Usually, obviously, 2 ways that it causes the big problems is an increase in sugar levels. So it doesn't matter what causes, whether it's islets insufficiency, increased demand as you've got too much sugar in you, or a problem with the actual pancreas itself, you're going to get diabetes, which is an increase in the amount of glucose that is carried, which means an increase in the amount of glucose that is lost, and that massive osmotic draw that is going to draw a huge amount of fluid outside the person. So the person is going to feel very hungry because they're chasing their glycemic index. They're going to be very, very thirsty, and they're going to be chronically dehydrated and hyperosmotic. On top of that, because of the lack of insulin or the inability for the sugars to get into the cell, we have an increase in fat broken down to be used for energy. So we have a lot of free-floating fatty acids, and can be a huge risk associated with plaque and cholesterol. But then, because the body has to use these fatty acids in the cells, because the glucose can't get in there, we get a bunch of ketone bodies forming. When those ketone bodies form, it causes ketoacidosis. And this mixture of hyperosmolarity and ketoacidosis can put you into what's known as a diabetic coma. So that can be quite an acute and emergency-based complications of diabetes. More of your long-term complications of diabetes often results from damage to small and large vessels. So small vessels get what's known as microangiopathy, whereas large vessels get macroangiopathy. So when we're looking through the body, cardiovascularly, you get atherosclerosis and gangrene of the extremities. You get kidney glomerulosclerosis and pyelonephritis is very common. Eye disorders like cataracts building up, retinopathy, and then you can even get cerebrovascular disease and peripheral neuroplasty as a result of your diabetes. Now, on top of that, just to make things worse for these poor diabetics, is you can have an overall reduction in immunity, impaired wound healing, loss of autonomic neuropathy can cause sexual dysfunctions, depression is quite common, and you can also obviously have that risk of going into a coma just for not being able to regulate your sugars. And with a coma, obviously you've got death, cardiac arrest, and the rest. So it's quite a nasty disease to have, and definitely long-term considerations with diabetes mellitus. Okay, that is endocrine pathophysiology completed. Now, I do apologise, it is a very rushed one. The main intent for this one was to give you an overview of all the different types of disorders that you can have. Now, obviously, each one of those disorders can have an hour lecture on just them alone. Okay, but the intent for this lesson was to look at the endocrine system, try to nut down the basics of pathogenesis within the disorders, and then get an introduction to the disorders that can occur. Until next time, take care.